to that door. They have to queue up, just like it's happening nowadays. When you go to a store, they have restricted the entrance, and there is a lot of people who are standing outside in the queue. So this could be this poses a problem, and this decreases the concentration. So we call these doors in the cells as sporin channels. The sporin channels could be changed. There could be mutation. There could be change in the color or the size of the sporin channels. Whatever the reason, the entrance of the cell, the entrance of the drug inside the cell has been decreased. So the mutation or change in the sporin channel decreases or poses a form of resistance for the entrance of the drug. This is one mechanism. The second is the receptor. Okay, if the foreign channels are okay, the door is fine, there is nothing wrong. All the students enter through the door inside the cell, but they have to sit on the chair, the proper chair, the chair that has been allotted by giving the roll numbers. Roll numbers, they are misprinted, the roll numbers are not there. So there would be some problem in the students. They would either they would keep on searching their roll numbers on the chair, or they would go out of the class. Or if it's too hot inside the class, whatever the reason, the concentration or the number of the students in the class would be low. Similarly, when the drug enters through the porin channels inside the cell, the receptor is changed. There's some mutation or change in the receptor, which is in this case is a ribosomal protein. So the drug would not be able to bind, or the whole concentration of the drug that you have given would be able to recognize the receptor, and some would go out or would be just lying there. So in this case also the concentration would be low, not the concentration that is required to produce the action or to eradicate or inhibit the growth. Third is the enzymatic. Okay, if the porin channels are fine, the door is fine, liposomal protein is fine, and they go inside, and once they start concentrating, the drug starts concentrating inside the cell, there is enzyme which is produced by the bacteria. Just like as in case of penicillin, there was penicillin enzyme, the beta-lactamase. This causes or renders the drug inactive, and it although the concentration is fine, but this enzyme which is produced by the bacteria, it inactivates the entering enzyme, and the concentration would become low, so low that it would be unable to eradicate the infection. Number 4 is the efflux pump. If all three mechanisms, or the porin channels, there is no enzyme which is produced by the bacteria, the porin channels are fine, the receptor protein is fine, but before binding to the receptor protein, there is an efflux pump. This efflux pump, it effectively extrudes out or excludes or throws out the drug out of the cell. So either of these mechanisms is true, or maybe one or two mechanism could be true for the drug, which is responsible for producing resistance in the therapy that you have employed. In case of tetracycline, the most important mechanism of resistance is the production of enzyme by the bacteria and the production of a efflux pump. So this could be true. Just hold on. I told you, please. Yes, of course. You want me to repeat? You want me to repeat the? You want me to repeat the mechanism of resistance? I'll go again. Hello? Do you want me to repeat the mechanism of resistance? Okay, fine. Okay, so what I told you that, listen, if somebody asks you in the examination the mechanism of resistance of tetracycline or penicillin, and you are unable to remember the specific mechanism of resistance for that particular drug, resistance means that you have given the drug in the appropriate therapeutic dose, and you have, okay, I'm sorry, really. Okay, I'll change the slide. Are they now changing? Can you see the slides now? Okay. Now we are okay. Now, can you see the slides now? Can you see the new slides now?
Yes, ma'am.
Okay. Okay. So mechanism of resistance. Okay, fine. So let's come to the mechanism of resistance. So for a drug to act and be effective and produce the action that you require, in this case, we require the eradication of infection. We want the appropriate therapeutic dose. Okay, I'll just go through one by one. You can see the slides now. The tetracyclines, now this is the classification of the tetracyclines, the short-acting, intermediate, and long-acting. Can I change the slide now? The tetracyclines, I told you that they're hydrochlorides, and the hydrochloride form is the most soluble form. So we give in the hydrochloride form rather than in free forms, except for chlorotetracycline. Then I told you the spectrum. That is, the spectrum means the bacteria or the organism that they cover. So tetracyclines, they are wide spectrum or broad spectrum antibiotics that they are active against many gram-positive and gram-negative organism like anaerobes, rickettsia, chlamydia, many protozoal species like amoeba, then Plasmodium falciparum, many L forms. The antibacterial activity, I told you that all the tetracyclines, they are similar in their pharmacodynamic properties that in their spectra with a very little difference except for cycline and doxycycline, which I would highlight and even in the slide and will tell you from time to time that what is different. But basically, the tetracyclines, they differ pharmacokinetically and very little in clinically. And then I told you that when they enter into the cell, it is by active, like just like all other drugs, they enter by passive diffusion and also by active transport, that is having a carrier mechanism. The drug, when enters into the cell, they concentrate and they bind to a receptor, which is a specific 30S ribosomal subunit. And by binding to this unit, they inhibit the addition of the amino acid to the chain, which inhibit the elongation of the chain and hence arrest the protein synthesis of the bacteria. And these agents, they are bacteriostatic in nature. I'll go to the other slide. Okay, so now we are on to the, should I proceed with the mechanism of resistance? You wanted me to repeat? Should I go on with the mechanism of resistance? Okay, so the mechanism of resistance, I told you, a patient comes to you, you evaluate the patient, you check the patient, you reach to a tentative diagnosis, and usually what the doctors, and of course you would, that you seeing the symptoms and you see that there's no need for culture and sensitivity, and you want to start with an agent, and you think that tetracycline is the best drug, and this choose a certain tetracycline and you start with the therapeutic dose. But after a day or so, the symptoms remain the same and the patient doesn't seem to respond. So we are talking about this scenario, that why the patient does not respond or doesn't seem to respond. So at this point, first of all, keep in mind that you are going to send the blood for culture activity, and then you would start keep on start continuing with the treatment that you have given. But you have to think that at this point, I'm trying to tell you that what could be the mechanism resistance, instead, in spite of all the you think the treatment that you started was okay. So these mechanism of resistance that the drug shows you, it could be because of the porin channels through which the drug enters. They could be mutation, there could be some change, they could, whatever the reason, the drug cannot enter properly, or the whole of the concentration of the drug you want, like 80 milligrams or 70 milligrams or whatever the therapeutic dose of the drug is unable to enter through those porin channels due to change in the porin channels, change in the door. I gave you the example of the door of the college. You enter through the gate, but the door is closed and there is some other door at the back of the college. So how many, like 100 people wants to enter, but not all 100 would be able to go to the back because there's no information and the door has been changed. So like the concentration or the number of students would be less to enter into the college. Some would go to the back, some would keep on wandering, some would go back home. So whatever the reason, due to the change in the door, the foreign channel, the drug, the concentration of the drug is low. So this is one mechanism. It could be for any drug. So if you are not able to remember a particular mechanism of resistance at the time of examination or your viva, just think of all these four mechanisms, and you can tell the examiner, gee, this is one mechanism. The porin channel could be changed. Second mechanism, the porin channels are fine, the door is fine, and the drug enters into the cell. Now the drug has to concentrate inside the cell. So there could be presence. The second mechanism of resistance could be the presence of an enzyme that is produced by the bacteria. This enzyme would cause the inactivation of the drug that has entered. The drug in concentration is fine, the transport is fine, but the enzyme that is produced by the bacteria, it renders the drug inactive. This would lead to resistance. The amount or the concentration of the drug that is required to eradicate the infection is not enough. This is second mechanism, that is inactivation of the drug by the enzyme. So this is second mechanism. The third mechanism is the receptor. The receptor which is present, it could be the penicillin binding protein in case of penicillin. It could be in case of protein synthesis inhibitor. It is a specific receptor unit, which is the 30S or the 50S or any subunit of the ribosome. This is the receptor. For any drug to act, a receptor has to be present. Now, this receptor has changed. There is some mutation. The drug would not be able to recognize the receptor. Some drug would recognize, or some subunits would be normal, but not so much to produce the drug, to make the drug effective, and this leads to resistance. So the third is the changes in the receptor protein. The fourth could be the resistance, the mechanism of resistance could be that everything is right, the porin channels, the entrance is right, is okay, the drugs enters by the passive transport or the active transport, then it accumulates and reaches to a certain concentration, fine. But there is presence of an efflux pump which is produced by the bacteria. This efflux pump, as the name tells you, would expels the drug out of the cell. And of course, the expulsion of the drug out of the cell would lead to decrease in the concentration of the drug and hence would make the drug ineffective. So now we have four general mechanisms. First is the porin channels, the changes in the porin channel. Second is the receptor protein, changes in the receptor protein. It could be, so these are two mechanisms. I'm talking about general mechanism. Number three is the presence of an enzyme or the production of an enzyme by the bacteria. Number four is the efflux pump. So these are four general mechanisms. You have to just memorize these mechanisms. Even if you can't remember the specific mechanism, you can tell the examiner, like, these are the four mechanisms. I'm unable to specify for tetracycline. For tetracycline, the most important mechanism of resistance is the production of the enzyme by the tetracycline, which would make the drug ineffective. And number two is the presence of an efflux pump by the bacteria. If you remember, I told you in penicillin, the most important mechanism of resistance in penicillin was the production of an enzyme which was beta lactamase. Can I go? Can I proceed? Okay. So let's see the pharmacokinetic. For the pharmacokinetic, the most important absorb and the bioavailability. The bioavailability, you all know, is the amount of the free drug that is going to produce the effect. So for that, you have to see that after oral administration, the drug distributes equally and very effectively in the different compartments like plasma, like extracellular fluid, and the intracellular fluid. So after that, what happens that the absorption for different after oral administration, the percentage of the oral administration is different, which depicts the bioavailability, which is important to know. So here it's given that after oral administration, chlortetracycline, the absorption is about 30%. Now this gives an idea about the how many times you have to give the dose. And of course, 30% is low, that it is undergoing extensive first pass metabolism, and you have to give like 3 or 4 doses. Now, 60 to 70% for tetracycline and oxytetracycline, it means that the absorption is good and there is first pass effect, but the bioavailability would be good. So it might need tetracycline and oxytetracycline would require two orbedias, like twice daily. Now, for minocycline and doxycycline, the absorption is after oral administration is about 95 to 100%. That is very negligible amount is eliminated from the kidney. It means that once daily dosing is required or is possible with doxycycline and minocycline. Whenever once you know that in clinically a doctor once daily dosing, and for the patient it's sort of a blessing that the patient, the compliance of the patient is good because he only has to take once daily dosing. And for the doctor also, monitoring is easy, you know, by seeing this ADME processes, that is absorption and distribution and absorption and elimination, that how much dose is given, and it's easy and the toxicity is low as compared to those which have to be repeated again and again. So now let's see the absorption. Now, all the drugs, and there's a misconception about antibiotics that the antibiotics should not be given empty stomach. But please, you have to convince your patient and you have to remember yourself that almost all the antibiotics, unless and until it is specified, they should be given empty stomach. Otherwise, the drug is going to, the food is going to hamper with the absorption and the onset of action and the absorption of the drug, and hence the bioavailability would be erratic. The people are like, ये दवा गर्म होती है और इसको खाना नहीं चाहिए, खाली पेट नहीं लेंगे. अच्छे अच्छे पढ़े लिखे लोग are like, खाली पेट तो नहीं लेना, कुछ खा के लेना. Unless and until it is specified, or should be, it's the duty of the doctor to tell the patient कि खुदा के वास्ते इसको खाली पेट लें, इससे कुछ नहीं होने वाला, ना ये गर्म है ना ठंडी है. The drug, the antibiotics, they act best when they are given orally. So let's see the absorption of the tetracyclines. That absorption is mainly as it's given orally. It is passes. It's an acidic drug. Is passed stable at the gastric pH, and it needs to be absorbed in the upper small intestine. If food delays it, except for mino and doxy. Now you have seen that there's some good points as would be seen by the clinician. The minocycline and doxycycline, they have a longer half-life. They can be given as once daily dosing. And now food should not be given with tetracycline, they should be taken empty stomach except for mino and doxy. Doxycycline and minocycline, they can be given with meals or with food. Dairy products and antacids. Antacids, like a person has ulcer, you have to ask the patient if he's taking any antacids. Antacids, because they contain magnesium or calcium, they should not be given with tetracyclines, neither the dairy products like milk, yogurt, or cream. Divalent cations, they hamper with the interfere with the absorption. For example, calcium, magnesium, and ferricine. Alkali medium, of course, because tetracyclines, they are acidic drugs, should not be given with alkaline. So you have to make sure that the person is not taking any antacids or alkalis or there should be a gap between the drug and the taking of all these cations or the dairy products or antacids. For intravenous use, mostly tetracyclines, they should be given orally, but they're specially buffered solution as they're acidic. So for intravenous administration, especially buffered solutions, they have been formulated by the pharmaceutical companies. When they're given orally, they distribute, as I told you, in all the body fluids, and except with the exception of the cerebrospinal fluid or the central nervous system, as compared to the plasma and the extracellular fluid or the intercellular fluid. Now, one important thing that I would like to mention here, that when the tetracyclines they are given, they chelate to calcium. Now, chelating agents are those that they change the chemical structure of those substances to which they bind. So when tetracyclines they are given, they chelate. They have a tendency to chelate to calcium. Calcium, so it means the calcium they could damage enamel of the teeth, which has calcium, and to the growing bones, and of course to growing teeth. So they should not be given in children when they are growing, like 6 to 7 years of age, when the dentition is being to permanent teeth when they are coming out. So because of their changing the configuration or the chemical structure of the calcium, they should not be given to children under 7 years of age, because they retard the growth by chelating to the calcium in the bones and in the teeth. The main organ of excretion is kidney, and also they are excreted by bile. And for example, doxycycline is has extrarenal mechanism. Now, this is important because the extrarenal or non-renal mechanism enables doxycycline to be given in people who have kidney problem or renal insufficiency. So whenever it is given that the elimination or excretion is specified, that they are excreted by non-renal mechanism, by biliary mechanism, or it means that they could be given in people who have renal insufficiency. So this makes them safer drug for those people who are cannot be given other drugs which have renal problems. Now, uh, okay, just hold on. There's some problem. Uh, okay. Now let's see the clinical uses. Clinical uses means that what is the spectra or the infections or pathogens against which tetracyclines or the diseases. See, spectra means the gram-positive or the pathogens, that gram-negative, gram-positive protozoa against which these tetracyclines they can be given. So this means the spectra against which they are active. And clinical uses, whenever you are asked about the clinical uses, it means the diseases against which any drug is active. So in here, the tetracyclines, they are the drug of choice. जब भी आपसे clinical use पूछा जाए, तो kindly you the thing that should jump in your mind should be the diseases. यानी examiner आपसे diseases पूछ रहा है, आप pathogens नहीं बताएंगे. जब आपसे spectra पूछ रहा है, spectrum of activity, the spectra of a certain drug, you should start with the pathogens. आप उसको कहेंगे mycoplasma हो गया, spirochetes हो गए, gram negative, gram positive के 2-3 example आप याद कर रहे हैं. So this should be unless and until she asks you the clinical use बताएं, तो you should start with the diseases always. So tetracyclines, they are the drug of choice for infections which are caused by Mycoplasma pneumoniae, chlamydia, rickettsia, and some spirochetes like Treponema pallidum. They are used in combination to treat gastric and duodenal diseases. Now you have, I don't remember whether you have done the peptic ulcer or the GID, but I would like to mention here that there are certain drugs which are specific drugs or class of drugs that are used for the treatment of ulcer and the gastric peptic disease. But in certain cases, for example, when the ulcer has been infected and is caused by Helicobacter pylori, which is an organism makes the ulcer resistant to be treated by the particular drugs which are used for gastric and duodenal disease. Kuch cases mein you see that the person does not respond to the typical drugs that are used for the peptic and duodenal ulcer. In that case, you send the tissue for or the secretions for to the lab, and you see that the person has infection with Helicobacter pylori. In this case, you have to give a certain regimen, a triple regime, in which an antibiotic is added to the specific anti agent. यानी जो आपने H2 receptor blockers दिए, which are used for the treatment of gastric duodenal disease, you have to add a proton pump inhibitor and an antibiotic. So I'm talking about this regimen, the tetracycline or aminoglycoside, they can be used, should be used to treat the gastric and duodenal disease, which is infected by Helicobacter pylori. Okay, so just hold on. There's some problem. I have to see. Just hold on. Just hold on. There's some problem. Okay, fine. Can you see the slides now? Can you see the slides? All right. So the tetracycline, they are active against these agents that I just you can see on the slide, and they are used in combination in cases of gastric peptic ulcers, which are infected with Helicobacter pylori, confirmed by the lab. So you add a tetracycline, and they respond well. In many gram positive and so it's a wide spectrum antibiotic. It is bacteriostatic. It is given for many gram positive as well as gram negative organisms. In most cases, for cholera, Vibrio infections means the Vibrio commerciate pathogen which is responsible for producing cholera in many malarial infection, including sexually transmitted diseases. It was used previously for coccal infection, which is the Neisseria gonorrhea, which is also a causative organism of a sexually transmitted disease, gonorrhea. So they are not used because of the emergence of resistance, and these agents, these pathogens, they do not now respond well to tetracyclines. Tetracyclines in combination with aminoglycoside, they are given for for tularemia and brucellosis. Now, plague, brucellosis, and tularemia, they are quite resistant to be eradicated by solo therapy. So, a combination of an aminoglycoside, which is specifically used for gram-negative, they should be used in combination with a tetracycline, and these respond well. They can be eradicated. Sometimes a protozoal infection like Entamoeba histolytica. Entamoeba histolytica has a certain range of drugs that are used for the treatment, but sometimes a combination of these agents along with the tetracycline, the Entamoeba histolytica can be eradicated in a shorter duration of time rather than with its specific drugs alone. Same is the case with Plasmodium falciparum, which is the causative pathogen for malaria. We have anti-malarial agents, but adding a tetracycline in this therapy could is seem to have more effective results. So kindly note this down that entamoeba, you could be asked that which antibiotic could be given along with the drugs that are used for the treatment of entamoeba histolytica or in case of Plasmodium falciparum. So you should remember that tetracycline can be used. Tetracycline, they're used in a very small dose of like 0.25. You don't have to remember the dose, but sometimes the dose is important to be mentioned to make it to highlight the importance of that such a small dose of 0.25 to 0.50 grams in adults is effective and is bacteriostatic. And a high dose could be used for serious infections. Now coming to the adverse effects. Now the adverse effects, you'll know that could come if the doses that are used, they go beyond, or if the person has some diseases or in old age or in children. Children में तो हम 6 साल 7 साल से छोटी उम्र के बच्चों को देते हैं. Before going on or embarking on these adverse effects, which you can see on the slide, uh, please tell me, can you see the slide, students? Can you see the slides?
Yes, ma'am.
Okay, thank you. Okay, so the common, please write it down, the common adverse effects. The most common, before we go on to these side effects or adverse effects that are written on the slide, the most common effects, as you all know, I hope you now all have comprehended that the common effects that can occur due to any antibiotics, if you can't remember any specific ones, are the GI upset because of the interfering with the normal flora that is present in the mouth and the GIT. So the normal common side effects are nausea, vomiting. That is the first one, GIT. Associated with GIT are nausea, vomiting, diarrhea, loss of appetite. That is common because they disturb the normal flora. The other one is the swelling of the tongue and change of color of the tongue to a darker shade or black. And if there are the bumps or the raised areas could be seen on the tongue that gives an effect of a hairy tongue. The hairy tongue could occur due to certain food and certain other reasons are positive. They are for other agents or drugs that are certain other agents. But cycling, they can also give this side effect of a black or hairy tongue with bumps. The bumps in the tongue gives an appearance of a hairy tongue. And this is reversible. That once the drug stop, this is an reversible side effect. The other sign is the difficulty in swallowing. The persons who are taking, the people, the patient who are given tetracycline and they are taking tetracycline for a longer duration, they continuously complain of sore throat and difficulty in swallowing, and this is because of the swelling of the in the throat and a sore throat sort of side effect. These are the common side effects. Number 4 is the itching in the genital and the rectal area, a swelling and a low grade sort of inflammation in the genital and the rectal area, and itching in the genital and rectal area. One important thing that I mentioned is that the tetracycline, they should not be given in children under 6 or 7 years of age when growing and when the dentition, the permanent teeth are being replaced by the replacing the milk teeth, because the tetracycline they are chelating agents. They have the ability to chelate to calcium, and chelating means that they change the configuration of the calcium, and hence they interfere with the growth of the bone, and they cause permanent brown staining of teeth. So note it down that I usually ask a scenario that, I don't know about the other teachers, but this is my favorite scenario that I would tell you in a moment, that the bone and teeth, a question that I usually ask the normal question or a BCQ has been made that which agent or tetracycline should not be given or contraindicated in children under 7 years of age or in pregnancy, because in pregnancy it would have the same effect, it crosses the placenta and they would affect the growing fetus. And one scenario I asked from the patient, from the student, is that you are sitting in your clinic and a mother comes with a child and the child gives you a smile, and she has come from some infection from with other symptoms, like she tells you that the child has some rash or he has been coughing or something, but you at once know by seeing the smile of the child, and when you ask, mother tells you about the age of the child, that he's 9 years old, and you at once know that he has been given some antibiotic which should not be given at that age. So this is a scenario that I asked that which antibiotic you think was given to the child. So by smiling, you can see the discoloration, and by knowing the age that he looks like a 5 year old kid instead of a 9 or 10 year old, that you know that tetracycline was given before the 6 years, or before the child was 6 years old, and it has stunted his growth and has caused discoloration of the teeth. The discoloration of the teeth is permanent. So you should always take care about this antibiotic that should not be given in pregnancy, neither in children of 7 or 8 years of age. Liver toxicity can occur in the form hepatitis, or it could be biliary obstruction. Kidney toxicity only occurs if the person or the patient already has some kidney problem. Only then it can cause kidney failure or different types of kidney nephritis. Local tissue toxicity, as the name tells you, could occur because when you're giving injectable and the solution is not properly buffered, it can cause different local tissue toxicity that can range from bruising to hematoma formation or abscess formation at the area of the injection. Photosensitization is specifically seen with demiclocycline. Demiclocycline can cause photosensitization when if the person is taking demiclocycline, he should be asked not to go in the sunlight because it causes sunburn sort of a photosensitization, and it becomes sensitive to the sun and would lead to some sunburn type of uh, reaction. So this is seen only with demiclocycline. Now, vestibular reaction. Vestibular reaction means that the person experiences imbalance or discomfort in the vestibular symptoms which are associated with the brain, headache, and it could be imbalance and ataxia. So these were the side effects, and we have done with the lecture. And now you can have your questions and come up with the questions or anything that you haven't understood. Uh, any question you want to ask regarding this lecture? Uh, as we have started with the infectious drugs that are used for infectious diseases, and we are at the moment doing the antibiotic. So there is, you must have noticed that there is a certain regimen or certain style for all antibiotics that you go on. First, the classification, then there is the spectra, then you know that the absorption, that what is important points that should be noted for the absorption of certain agents, pharmacokinetic and dynamic, then the mechanism of resistance. That is true. Okay, you want me to repeat slide 2 and 3? Just hold on. You want me to repeat? You want me to repeat slide 2 and 3? Two and three? Okay. Okay. Slide 2 and 3. Let's go back to slide 2 and 3. One. Are you asking about the spectra? Spectra?
No, ma'am, the adverse effects side.
Adverse effects? Somebody said slide 2 and 3. Adverse effects? Okay, fine. So, the adverse effects are, first of all, I just want you to remember that for all the antibiotics, something which is true for all the antibiotics, that when you are asked the adverse effects, सारी antibiotics, जो भी आप लेते हैं, जो भी patient को देंगे, that are going to affect the normal flora that is present in the GIT. And because by disturbance of the normal flora, the patient to different range, different what should I say, that they could have multiple problems in related to the GIT, which is nausea. They could have more nausea. They could have more diarrhea. So nausea, vomiting, diarrhea, and the agents affecting the appetite. There is loss of appetite. So these are the nausea, vomiting, nausea, vomiting, and diarrhea. And before that, I told you that there are certain effects which are not mentioned here in the slide. They are the patients, they have problems in swallowing. This is because of the swelling of the in some swelling in the throat in patients who are being administered for the no, not adverse effects. Somebody said as well. Kindly tell me specifically. All right. Actually, 1 and 2. 2 was the effects. That is the antimicrobial activity. Antimicrobial activity, you want me to read that? The spectra of the drug. The spectra. Slide 2 to ये है. All right. So the spectra, let's see that the against which organisms these agents they are effective. So the most important agents, tetracyclines, they are kuch drugs हैं. For example, I'll give you an example that some drugs like penicillin, they are mainly effective against the gram positive, and to make them effective against gram negative, कुछ मैं चीजें कर देती हूँ. I'll tell you about the spectra and then I will go. Somebody said slide 2. Slide 2 is about the spectra. So I'll repeat both of them. We have time, so I'll repeat both of them. So spectra means that कौन से pathogens हैं जिनके खिलाफ they are more active. So being a wide spectrum antibiotic, tetracyclines, they are effective against many gram-negative and gram-positive bacteria. For example, those agents like gram-negative, which are responsible for infections like cholera, for gonorrhea, for syphilis, for rickettsia, for chlamydia, and in addition to that, they are also effective against some protozoal infections like Entamoeba stollitica when the person patient doesn't seem to respond to the typical drugs that are employed for amoeba. And then Plasmodium falciparum. In certain cases of Plasmodium falciparum, when the patient does not respond to those, with action of a tetracycline, it seems to respond well to tetracycline. Okay, I'll come to the adverse effects in a moment. So, यानी टेट्रस जब हमने penicillins किया था, penicillins they are basically active against gram positive, and to make the penicillin active against gram negative, we made a certain class. Cyclines themselves, they are a wide spectrum antibiotic, and they are active against both gram negative and gram positive, and also in cases of when the person has ulcer and he doesn't seem to respond to the typical H2 receptor block, and addition of tetracycline for cases in which the person has Helicobacter pylori is positive from the lab, he responds well. Then in cases of tularemia, plague, and brucellosis, tetracycline in combination with aminoglycoside, they are given and the patient responds well. So now let's coming to the adverse effects. Kindly write it down that there's some effects which are common. First of all, the GIT effects, that is nausea, vomiting, diarrhea, and loss of appetite, which is most common side effects that are seen with the administration of tetracycline. Then another effect that is seen is swelling of the throat, and which leads to difficulty in swallowing. Because of the swelling and some inflammation in the mouth with the patients who are receiving tetracycline, this is a common effect that they keep on complaining कि मुझे ऐसा लगता है मेरा गला खराब है, मुझे थूक निकलने में या खाना खाने में प्रॉब्लम होती है. So you should tell the patient that this is a side effect of the drug, will go off once the drug is stopped. The patient को समझ आ जाएगा. So this is your duty to tell the patient that this is a side. जब आप शुरू करें तभी आप उसको बता दें कि जी ये एडवर्स इफेक्ट हो सकता है कि आपको ये डिस्टर्बेंस हो सकती है, डिफिकल्टी इन swelling हो सकती है, swallowing हो सकती है, and there could be itching in the rectal and anal area and also of the genital. Then most important effect that they could adverse effect they could have if they should contraindicated in children under 6 or 7 years of age because of the eruption of the immunity and the growing bones, because tetracyclines, they are chelating agents for calcium. Chelating means that they bind to the calcium and they change the configuration, and hence they would interfere with the growth of the bone and the enamel of the teeth, leading to stunted or retarded growth of the children and the discoloration, permanent brown discoloration of the teeth. Then liver toxicity and kidney toxicity is only seen if there is already some infection in the liver and kidney. Local tissue toxicity, मैंने आपको बताया कि local tissue में injectable दिया, the solution may not be properly buffered, to can lead to inflammation that can range from from bruises to abscess to hematoma formation. Then photosensitization, that person becomes sensitive to the light, is seen with demiclocycline, and if the person who is taking demiclocycline, if he goes out in the sunlight, that can lead to sunburn sort of a reaction, which is not permanent. Vestibular reaction seen with minocycline, and this reaction can occur in the form of imbalance, ataxia, or vertigo. Another one which I told you initially, uh, initially was hairy tongue. Hairy tongue, कभी आपके BCQ में या टीचर पूछ लेता है कि hairy tongue, वो आपसे स्पेसिफिकली पूछेगा एग्जामिनर कि hairy tongue किस एंटीबायोटिक का साइड इफेक्ट हो सकता है, because hairy tongue can occur with number of foods or with other drugs besides the tetracycline. So tetracycline can cause hairy tongue, which is the black discoloration or dark discoloration of the tongue with bumps on the tongue, giving an appearance of a hairy tongue. But this is a reversible reaction, and it goes off once the person has stopped, when the drug is has stopped, has been stopped. Any other question you want to ask? Because the time is up. Is it clear? Okay. Thank you for being here. And I would, if you want any other question, you can email me. I'm giving you my email. Okay, just hold on. If you want to ask any question regarding the lecture, feel free to email the questions. I will explain it to you. Okay. Allah Hafiz, and keep taking care of yourself. Stay safe and stay inside. Allah Hafiz.